This is part 2 of this 2-part series on Ebola. This part will focus on the transmission, diagnosis, and treatment of Ebola, along with basic principles of effective infection control. The learning objectives of this video are to be able to describe the life cycle, transmission, and presentation of Ebola, to identify a suspected case of Ebola and describe the means of establishing a definitive diagnosis, to list the current approaches to treatment, including those considered experimental, and last, to list the critical components of effective infection control. So in part 1, I discussed that Ebola is a virus that causes sporadic outbreaks in Africa, and that in between outbreaks it hangs out in a non-human reservoir. There is strong evidence that this reservoir is bats. And the virus continues to replicate within the bat population in something called the enzootic cycle, meaning this is its native or baseline host. Occasionally, when either general conditions are right, or as a consequence of a single chance event, the virus spreads to other animals, such as non-human primates, and it can replicate within these other animals and jump back and forth between bats in something called the epizootic cycle, meaning these are not the typical hosts for the virus. And the epizootic cycle can also involve humans, either directly from bats, or from primates, or most commonly from other people. So in the case of Ebola, how exactly does that transmission occur? There are 2 proven modes of transmission. Over 99% of cases between people are transmitted through direct contact of broken skin or mucous membranes with infected body fluids, which can be just about anything. Blood, feces, and vomit are believed to be the most infectious, but Ebola can also be spread via urine, semen, saliva, and breast milk. For example, a patient suffering at home with undiagnosed Ebola vomits on themselves. Their spouse or other family members help to clean them up, and with hand soiled with the vomitus, even trace amounts of it, rub their nose or their eyes. The virus can even sneak in through imperceptibly small breaks in the skin of the hands that a person might not even realize are there. In addition to this mode, a tiny fraction of healthcare workers have been infected by breathing in aerosolized virus during medical procedures, which specifically create large amounts of aerosolized respiratory secretions. This would include bronchoscopy, sputum induction to obtain a respiratory culture, and potentially deep respiratory suctioning. This is not the same thing as stating the Ebola virus is airborne in general, which it is not. In addition to proven modes of transmission, there are also suspected modes of transmission. This includes direct contact of broken skin or mucous membranes with sweat or with contaminated surfaces. For example, a person with Ebola is sweating profusely from a high fever and grabs a door handle. Several minutes later, another person grabs that door handle and before washing his or her hands, rubs the nose or eyes. This has not been proven to happen, but infectious disease experts believe it's possible. These must be contrasted with modes of transmission neither observed nor suspected. There are 2 main ones. First, airborne transmission outside of medical procedures. So you will not catch Ebola by simply walking past a patient in the hallway, provided you don't touch that person's bodily fluids, or any object that person has also touched. Another mode of transmission which has not been observed is transmission via mosquitoes and ticks. Unlike some other viruses, Ebola is incapable of surviving in blood-sucking insects. A few more important points about transmission. Patients with Ebola have only been observed to be contagious once they are symptomatic. This is a key factor and explains why asymptomatic Ebola contacts can continue working and interacting in their community. I wouldn't necessarily get on an 8-hour plane ride as an asymptomatic contact in the event symptoms on board develop, but contacts do not need to shutter themselves in at home. Next, just to emphasize again, Ebola is not airborne. Finally, and this will likely be a surprise to most of you, but the maximum possible incubation period for Ebola is calculated to be about 25 days, which is obviously longer than the 21-day cutoff the CDC and public health officials discuss in the media and report